In this video, we'll review the symptoms of depression and discuss the diagnostic criteria for a major depressive episode in the DSM-5. The hallmark symptoms of a major depressive episode are changes in mood. The first symptom is depressed mood, and this can be manifested in several different ways. So one of the primary ways that we can see depressed mood is that an individual will subjectively report that their mood is sad. They might describe feeling sad or down in the dumps or low, or say that they have the blues. They might use metaphors, things like saying, I feel like everything is dark, or I feel like I'm in a hole. So many patients will subjectively describe this sadness, and that depressed mood might be one of the reasons that they are seeking treatment. However, there are other ways that this sadness can be expressed. So one is through objective appearance. So for example, if an individual says their mood is fine or their mood is okay, but they appear tearful or they are crying during the interview, that would be another sign that they may be experiencing depressed mood. And finally, there are some developmental considerations when we are assessing depressed mood. So for example, in children and adolescents, sometimes depressed mood will manifest as irritability or anger. The second possible mood symptom is anhedonia, which refers to a loss of pleasure, interest, or motivation. This can also take a range of forms. So some individuals will report that they no longer experience pleasure when engaging in activities that they used to enjoy. For others, it will be more pervasive. They experience a loss of pleasure in nearly all activities. This can also manifest as a loss of motivation or interest, which behaviorally you'll often observe in a decrease in behavior. So people will be doing fewer things. They might be not going to work or going to school every day. They might not be keeping up the house at home or might not be cooking, or you might see a drop off in social activities. So no longer going out with their friends, no longer reading for pleasure or watching TV shows that they used to like. So you can see a lot of behavioral changes generally characterized by a decrease in behavior. And to meet criteria for a major depressive episode, one of these mood symptoms needs to be present. So an important thing to know about major depressive disorder is that it can be present even in the absence of this depressed mood. So if an individual is experiencing significant anhedonia, even if they're not experiencing subjective sadness or if they don't look depressed, that loss of interest or loss of pleasure can fulfill this criterion for one of the mood symptoms. So for many individuals, depression is characterized by this subjective sad mood, but for others, they experience it more like a neutral mood, or they might say they feel like they're not having any feelings or feel kind of empty, but are experiencing significant anhedonia. The second set of symptoms are somatic symptoms, and these have to do with physical symptoms. And a really interesting thing about this set of symptoms is that many of them can manifest in opposite directions. So the first somatic symptom are changes in appetite or weight, and these can go in both directions. So in some individuals, you'll see a decrease in appetite, often associated with significant weight loss. In other individuals, you'll see a significant increase in appetite, sometimes associated with increased eating, called hyperphagia, or weight gain. So for individuals who experience a decrease in appetite, sometimes they might say that they're never hungry, that they need to be reminded to eat. If an individual does not know their weight, sometimes I will ask about how their clothes are fitting. So I'll say, have you noticed that your clothes are fitting more tightly or more loosely, or has anybody commented on any changes in your appearance? And this is another symptom where we need to take development into account. So in children and adolescents, it may not be weight loss or gain, but it may be a change in the trajectory of their weight. So for example, in a child who was in a particular weight percentile and had stayed in that percentile, if their weight drops off, if they stop gaining weight at the same developmental trajectory, that might be a sign of changes in their appetite or eating patterns, or if the trajectory of weight gain increases in a way that looks accelerated compared to their previous developmental trajectory. So for all of these symptoms, we always want to be taking into account someone's developmental stage and also their previous functioning. In addition to changes in appetite and weight, we can also see dysregulation in sleep. And just like with weight, we can see changes in opposite directions. Many individuals with depression will report experiencing insomnia or difficulty sleeping. There are different kinds of insomnia, and we define them based on their timing. So you can have initial insomnia, which happens at the beginning of the night when an individual has difficulty falling asleep. You can have middle insomnia, where someone wakes up in the middle of the night. They may wake frequently, or they may wake up and have difficulty falling back asleep, leading to long periods in the night when they are awake. Or you can have what's called terminal insomnia, which occurs early in the morning when an individual wakes up before their desired wake time and is unable to fall back asleep. Any of these can happen in depression, but middle and terminal insomnia tend to be more characteristic of depressive disorders. When we talk about anxiety disorders, we'll talk about the fact that initial insomnia is often present in anxiety disorders. But again, any of these kinds of insomnia can present in depression. On the opposite side, we have hypersomnia, or excessive sleeping. This might involve spending a lot of time in bed, some individuals up to a full 24 hours a day in bed, other than to get up and take care of some basic needs. It might be sleeping for an extended period of time at night. People might be reporting that they're sleeping 12 to 14 hours. It might involve frequent napping. And an interesting thing about this sleep dysregulation is that sometimes you can see both simultaneously. So you might have a patient who is experiencing significant insomnia at night, and then because of fatigue and sleepiness related to that nighttime sleep disruption, they may be engaging in excessive napping during the day, and that can fuel a really dysregulated sleep cycle. The next somatic symptom are changes in psychomotor behavior. And again, this can occur in either direction. So on one side, we can have psychomotor agitation. So this is when an individual's physical motor behavior is agitated or restless. You can see this as kind of nervous energy. They might be pacing or fidgeting. And an important change from the DSM-4 to the DSM-5 is that these psychomotor changes need to be severe enough that they are observable to an external observer. So it's not sufficient for an individual to say, I feel really wound up, I feel like I have a ton of nervous energy, but it's not visible to someone from the outside. So that was a pretty major change from the DSM-4 to the DSM-5. On the flip side of this, we can also have psychomotor retardation, where an individual's motor behavior is very slowed. So subjectively, sometimes patients will report, they'll say, it feels like I'm moving through molasses, or it feels like my body is heavy and it takes forever for me to move it. One way that I'll sometimes ask about this, I'll say, if you watched a video of yourself, would it look like we were watching you in slow motion? Or for agitation, would it look like you are speeded up? If you're interacting with someone in person, sometimes one way of doing this is to guide them down the hallway to wherever you'll be meeting them and follow them and see what their pacing looks like. So for example, if I need to pause or really slow my pace in order to stay with someone, that might be a suggestion that their walking is very slowed, that they are moving very slowly. So we can have these changes in psychomotor behavior, either that are agitated or that are slowed down, that are severe enough to be observable. And then our final somatic symptom is fatigue or loss of energy. This is a very common symptom of depression. Many individuals report that they feel very tired, that engaging even in just minimal exertion is really tiring and that they need to take a long time to recover. Or they might just have a loss of energy, that they are not even able to start engaging in a level of behavior that they previously were able to engage in comfortably. Our final set of symptoms are the cognitive symptoms. So these are changes in thought that are common features of major depression. One common symptom are feelings of worthlessness or excessive or inappropriate guilt. So many individuals with depression report that their self-esteem is low. They feel like they're not a great person. They feel not smart. They say, why would anybody ever want to hang out with me? I'm such a loser. This can also present as excessive or inappropriate guilt. So feelings of guilt about minor problems, minor conflicts, feeling a lot of excessive or inappropriate guilt about it. At the more severe end of the spectrum, if psychotic symptoms of depression are present, this might be delusional. People might feel guilty for things that they have not done, or believe that they should be punished, or even believe that they might be cursed or might be evil. So this can cover a whole spectrum, but in general, this symptom is characterized by negative self-perception and negative evaluation of the self. Another cognitive symptom is diminished attention or concentration or impaired decision-making ability. So many individuals with depression have difficulty concentrating. They have trouble keeping their mind on a single task. So when we talked about anhedonia, one example of a decrease in behavior you might observe is something like no longer reading books for pleasure or no longer watching TV or movies. And sometimes one symptom that can contribute to this is difficulty concentrating. So people will say, I've stopped reading books for pleasure because I can't keep my attention that long. I get halfway down the page and I realize that I zoned out and I don't know what's happening and I can't follow the plot. Or they'll say, I can't even watch a TV show because I find that I can't sustain attention for a 30-minute episode. So you might have significant impairments in the ability to sustain attention or to concentrate. And these changes in cognition can also manifest as indecisiveness. And this is not just difficulty making large decisions. This can be difficulty making even small decisions. So for example, someone might go into the drugstore to purchase shampoo and stand there in the aisle and feel really overwhelmed by all of the options and leave without buying any shampoo because there were just too many choices and they can't pick one. This can also interact with other symptoms. So for example, for someone who is experiencing decreased appetite, I've had patients say, I don't feel hungry, but I know that I should eat. So I go to the refrigerator and I open the door and I stand there and I just can't decide what to eat. And it feels so overwhelming that I just walk away without eating anything. So that might contribute to that cycle of decreased appetite and weight loss. And then our final cognitive symptom is recurrent thoughts of death or dying. And this can take a wide range of forms, ranging from intrusive thoughts of death. So some individuals just report that they are thinking about death, either in general or their own death, that they feel a little bit preoccupied with morbid topics, but they're not experiencing any thoughts of suicide or any desire to harm themselves. And on the more severe end of the spectrum, we can have suicidal ideation, so thoughts of harming or killing oneself. And these can also range on a spectrum from what we call passive suicidal ideation, that's characterized by perhaps a desire to die or a desire to be dead, but that is not accompanied by active intention to harm oneself. So one example of passive suicidal ideation might be an individual says, I wouldn't hurt myself, but if I just didn't wake up tomorrow, that feels like it would solve some of my problems. Or someone might say, it's occurred to me that if I stepped off of the sidewalk and got hit by a bus, that doesn't feel like it would be a terrible thing. So that would be an example of passive suicidal ideation. On the most severe end of the spectrum, we have active suicidal ideation. So this is a symptom that is present in some episodes of major depressive disorder. We do see increased risk for suicide completion among individuals with depression, and among individuals who complete suicide, many of them are experiencing a depressive episode at the time of the suicide. So this is a serious symptom. It's something that you want to screen all patients for, even if they don't indicate it voluntarily. You always want to assess if these thoughts are present. Active suicidal ideation would be characterized by thoughts of harming oneself, a desire to harm oneself. It might be accompanied by an intent. So in addition to wanting to kill themselves, they might actually intend to do so. And they might actually have developed a concrete plan to harm themselves. Or they may have gone so far as to work towards achieving the means to do so. So for example, if they have obtained a firearm, or if they have obtained medication that they intend to use for the purpose of a suicide attempt. So in any patient presenting with depressive symptoms, it's important to assess for the presence of suicidal ideation and to determine if there is active suicidal ideation and if there is risk that would be evident in the presence of intent or a plan or access to means. So to review, the criteria in the DSM-5 for an episode of major depression require the presence of 5 of the 9 symptoms that we just reviewed. One thing that I want to note is that in the DSM, they are not divided into these 3 categories. I find that categorizing symptoms into mood symptoms, somatic symptoms, and cognitive symptoms helps me remember all of them. But in the DSM-5, you can have any 5 of these 9 symptoms. They do not come from specific categories. But importantly, at least one of those symptoms must be depressed mood or anhedonia. So because this is major depressive disorder, you must have one of those symptoms of depressed mood. In addition, the symptoms need to be present for at least 2 weeks. And during those 2 weeks, the symptoms need to be present most of the day, nearly every day. So these are not transient depressive symptoms, but these are symptoms that are persisting for a sustained period of time and that are consistently present throughout that sustained period of time. In addition, the symptoms need to either cause marked distress or functional impairment. If you think about the symptoms of major depressive disorder, most individuals who are experiencing them are distressed by these symptoms. They are ego dystonic, and the symptoms can be very impairing. So if an individual is presenting with these symptoms over at least 2 weeks, typically they're experiencing distress or impairment related to these symptoms. And then finally, the symptoms can't be better explained by another cause. So the symptoms are not caused by a medical condition. They're not induced by substance use, either prescription medication or illicit substance use. And they are not better accounted for by grief. So in the DSM-5, they did get rid of what in the DSM-4 was called the bereavement exclusion criterion. So in the DSM-4, you could not receive a diagnosis of a major depressive episode within a time frame following the death of a close loved one. In the DSM-5, you can receive a diagnosis of major depression shortly after the death of a loved one, but the DSM includes some guidance for clinicians about distinguishing between a normative grief reaction compared to a major depressive episode. So they suggest that some individuals who experience a loss may not only be experiencing that normative grief, but may also be experiencing depression that meets criteria on top of that grief. And in those cases, now with the DSM-5, you can give that diagnosis of a major depressive episode.